A very good evening to one and all present virtually. I welcome you all to the 6th International Conference of RX Doctors, Day 13, organized by RX Doctors, organizing partner HTA Premier Research Institute, Chennai, powered by EWTI OECC, Radiant Health, Canada. We are truly honored to have you all today. Without further ado, let me take a moment to introduce today's speaker, Dr. Kritika Ma'am, Clinical Pharmacologist, Gleneagles Global Hospital, Chennai. Please join me in welcoming Ma'am for today's session. Ma'am is a highly accomplished clinical pharmacologist currently serving at Gleneagles Global Hospital, Chennai. She holds a Doctor of Pharmacy degree from CL Bade Mehta College of Pharmacy affiliated with Tamil Nadu, Dr. MGR Medical University, and a postgraduate diploma in Hospital Administration and Management from the National Healthcare Academy, Singapore. With strong expertise in clinical research, medical writing, and regulatory affairs, Ma'am has significantly contributed to the field through her international journal publications. Her work includes rare and impactful case reports such as classical Hodgkin lymphoma, Rasmussen encephalitis in pediatrics, and adult onset Still's disease, emphasizing her commitment to early diagnosis, awareness of rare diseases, and advancement of therapeutic approaches. In addition to her academic and research accomplishments, Dr. Kritika Ma'am holds certifications in oncology, SPSS statistics, and Lean Six Sigma Green Belt, reflecting her multidisciplinary skills and analytical abilities. She is widely recognized as an effective presenter and organizer with a unique ability to simplify complex medical concepts and translate them into practical healthcare solutions. Her professional areas of interest include pharmacovigilance, clinical trials, patient centered care, and bridging the gap between medicine and science to enhance healthcare delivery. Ma'am work and dedication exemplify her passion for advancing clinical practice, patient safety, and evidence-based healthcare solutions. Welcome, ma'am. Now the stage is yours.
Thank you, Ma. Thank you for the introduction. It was very grateful for meeting you all people here. So, myself, Dr. Kritika, from a clinical pharmacologist from Gleneagles Hospital, Chennai. So, I just need an introduction from you guys. Can you guys please give a self intro? Like, where are you from? Are you from family? Family graduates? Can you guys please give us intro? Anyone? Your college, your name, or your background? Yes, Vedat. So Vedat was the first one. Nice. You can also chat, no issues. Oh, that's nice. Jagan, right. Okay, that's very nice. Nice. So you guys are from family fifth year. It's very nice. Yeah, good. Prince. Yeah, okay. So you guys are very interested in clinical practice as clinical pharmacologists or pharmacists in hospitals. Yeah, good evening, Deeptika. Yes, Yogi Priya, Merlin. Okay, so yeah, so Mira. So most of all from family fifth year. Yeah, Hashita, hi. Hi everyone who are giving chats. Tamil and that's very nice. Oh, Tandai College. That's very nice. Okay, Bavadani. Karpagam College of Pharmacy. Very nice. Third year. And then, any more people to get intro?
Hi, ma'am. Myself, Bionisha. I'm from Grace College of Pharmacy, Kerala. Currently, I've completed my fifth year PharmD.
Okay, very good. Welcome to the board here. Yeah. So I think most of all the people got introed here. So I'm very happy and grateful for the introduction from our ex-doctors and for the session. So can we start the session? Yes. Joe. Hi. Joe Subisha. Or any more people to come? Okay. Hi, Thompson. Okay. So we will start the session now, and any more doubts you can ask here. You can approach me. Okay. Today's session is about renal and hepatic dose adjustments. Are you people are aware, as most of the people got introed here from 50-year background. So are you people are aware of how the renal dose adjustments have been done in the hospital? You people will be as interns in the hospital, right? Most of the people have been posted in the hospitals. So you guys are aware how the renal and dose adjustments or dosage calculations, pediatric calculations have been gone through the hospital. So what are the major priorities is being given as a clinical pharmacist in adjusting the dose adjustments for the drugs in the hospital? Okay, so we can have a glance. Okay, I'll just give a brief glance of what are all the parameters, and I want you guys to be much interactive so that I can give a solvation problems to you. I'll explain the concept. You just easily you can go with our formulas, and you can also have a session with us. Okay, like an interactive session. I can give a questions, and you can solve and tell me the answers. Um, at last, you'll be very clear with your renal and hepatic dose adjustments. So coming to the concept, mostly hepatic dose adjustments are being based with the drugs. Most of all our drugs doesn't require hepatic adjustments. But coming to renal adjustments, as our role in clinical pharmacist, as clinical pharmacist of hospital, most of our role will be having a renal dose adjustments in all the ICU and critical care units. In transplant units, you will be having a calls for adjusting renal adjustments of drugs in the hospital. Okay, for all the transplant medications, sure, the patient will undergo a renal failure, which is acute renal failure, which will be the acute renal failure. So you have to go through the renal dose adjustments for all the critical care patients. Like if the patient is having any volume overload also, mostly the commonly used renal adjusted drugs are the antibiotics. You have to be very familiar with the antibiotics and all the high-end antibiotics, restricted antibiotics just being used in the hospital. You have to be very thorough with your high-end antibiotics and restricted antibiotics just used in the hospital. Okay, we will have a brief session, and at last we can have some case discussions and Q&A sessions in between also, so that you can be very thorough with your formulas. Okay, will you people also be interactive with me? Okay, we'll start the session now. I'll just share the screen. Okay. So you guys can see the screen now. Okay, so today's session is on renal and hepatic dose adjustments. Renal and hepatic failure. So renal failure, kidney failure is commonly called as renal insufficiency, which describes a medical condition in which the kidneys fail to adequate filter toxins and waste products from the blood. And renal failure is described as decrease in glomerular filtration rate. And creatinine clearance may be defined as the volume of plasma cleared of creatinine per unit time. Okay, you guys are aware of creatinine, right? Creatinine clearance plays a very important role as a lab marker in indicating your renal insufficiency. Okay, it is calculated using a formula that is clearance rate of urinary excretion of creatinine by creatinine is equal to serum creatinine concentration. It is expressed in ml per minute. So liver failure or hepatic insufficiency is the inability of the liver to perform its normal synthetic and metabolic function as a part of normal physiology. It is also of two types, acute liver failure and chronic liver failure. Here, we have some important drugs which require dose adjustments in hepatic dysfunction. In your critical care units or hepatic transplant units, when you go rounds as a clinical pharmacist, this is a practical scenario what you see in a various hospitals. which includes our Chennai unit or Bangalore or Hyderabad or other institutes like Apollo, or you go for Mayot, or you go for any other institutes also. So this, as a clinical pharmacist, you'll have a practice of doing ward rounds. Okay, participating in ward rounds, you have to give dose adjustments and you have to give calculation of chemo drugs adjustments also. So this will be a major role. In consideration to drugs, when you see a case chart, when you're going for rounds, you have to be very familiar with some drugs which is related to a hepatic dysfunction. I have given some examples of that which is commonly used in current scenarios like NSAIDs, diclofenac. Okay, which leads to liver toxicity. So these drugs always require monitoring when we are going for drug chart checking or clinical practice wall drugs. Okay, that is amiodarone, anabolic steroids, chlorpromazine, diclofenac, erythromycin, methotrexate, phentoin, quinidine, rifampicin, warfarin, and antiviral drugs, antipsychotic drugs. Okay, abacavir, benzodiazepines, cyclophosphamide, diuretics, doxorubicin, fluorouracil, haloperidol, hydralazine, opioids, and prosinamide. So some drugs which we always see is your NSAIDs in all patient case sheets is your diclofenac, which is directly related to hepatic dysfunction, and it is your diuretics, and your opioids and your methotrexate drugs, which is all immunosuppressive drugs. So immunosuppressive antiviral drugs, NSAIDs, always play a very important role in your hepatic dysfunction. Okay, so some of the formulas which we commonly use for calculating hepatic dysfunctions for adults, we go with your end-stage liver disease, that is MELD, which is MELD is equal to 3.78 into serum bilirubin. What you get from the case sheets into 11.20, and it's your INR procalcitonin. What are the lab markers we see? Plus 9.57 into your serum creatinine level, plus 6.43, which is a constant for your liver disease etiology. For hepatic failure, you just go through all the drugs which can cause hepatic dysfunction or the dose adjustment need to be monitored, and you can go with the formulas for calculating the dose values. Okay, with your laboratory markers or patient case sheets, you can find the values of the markers. You can just note down the formulas which is used for the two type of people here. One is for adults and one is for pediatrics. In case which requires hepatic dose adjustments. Okay, which is quite rare. Okay, we always go just a drug dose in liver transplant patients. Okay, when you have a transplant unit in your hospital, which is a renal and hepatic liver transplant cases only need those hepatic dose adjustments. In normal critical care, you will be more commonly doing with your renal adjustments. Okay, so that is if the patient has been dialyzed twice in the last 7 days, the value for serum creatinine should be 4.0. If the patient, usually the patient in your transplant units, they will cause acute renal failure, liver failure. They will undergo. If the patient had renal transplant, the patient will undergo acute liver failure. Okay, if the patient has to undergo liver transplant, then it may cause renal insufficiencies. Okay, so these are the common things which will be happening in your transplant units. So this will be a formula for calculating adult end-stage liver disease patients. And for your pediatrics, it's a disease severity scoring system for children under 12 years of age. So that is a PELD. And we also use Child's Buck score. But these two formulas will be very helpful. If you see the drugs in your case sheets which needs hepatic dose adjustment, then you can go with your formula from your lab sheets. Okay, that is PLD is equal to 4.80 into in serum bilirubin mg per dl plus 8.57 in albumin, 4.36 plus 6.67 growth failure. Okay, and a higher score correlates with a more critical condition. Okay, that is the donations allocated by United Network for Organ Sharing, which leads to calculating the PELD score to maximize their life having capability for each donated liver. Usually we calculate the scores for your liver transplant patients. Okay. Okay, then comes your renal dose adjustment. Okay, so we have 5 levels on this in your renal dose adjustment, which is very common, which is creatinine clearance, hemodialysis, SLED, CRRT. Okay, so renal dose adjustment, the common formula what we use is our Cockcroft equation. Okay, the method of this used to estimate the creatinine clearance or the serum creatinine concentration. This method considers both age and the weight of the patient. Okay, for male and for female. Okay, so this is your formula, which is 140 minus age in years into body weight in kg by 70 into say mg per dl. For female, which is multiplied into 0.85. So, okay, you can have a question. Ma'am, it's my first time I'm calculating a dose adjustment for the patient. So what should I see? Okay, whenever you get a call from the unit, critical care unit, you're going and attending the patient, you have to go through the patient case sheet fully from first to last. You have to analyze the case. What is the case? What are the urine output level? If you're calculating renal dose adjustment, you should not go and calculate blankly with your formula. Okay, you have to go analyze the case sheet whether the patient got high level of creatinine due to the renal dose failure or any other condition the patient got. You have to go with your drug charts also. Whether duplication, therapeutic duplication of drugs have been seen in the patient or any other correlation had been happened which increases the renal creatinine clearance level of the patient. So we have to go through that and get your values like patient age, patient weight, and your creatinine level. Okay, serum creatinine level. Okay, it only measures the creatinine clearance value. Okay, this is the formula which we use for that. Get the three things. One is your age, because we are going to solve some problems now. So be interactive, guys. So age, weight, and serum creatinine level. You just get it from your case sheet, apply the formula, and you have to calculate your creatinine clearance value. Okay. Okay, so we have a question here now. A 90-year-old male patient had creatinine 1.5 mg per dl, whose body weight is about 62.3 kg. Calculate the creatinine clearance for this patient. How much it will be? Here it is 28 ml per minute. Okay, it's a sum number 1. You guys got it? Someone is on hold. Okay, yes. Good. So can I have a question to you so that you can solve the problem now? Can I give a value? You guys will tell me the thing, how much you're getting. Okay. 80-year-old female patient having a serum creatinine value of 2.1 mg per dl. Her body weight is 80 kg. How much will be her creatinine clearance? Can I repeat the question? Is everyone aware? Okay, 80-year-old female patient has a same as creatinine clearance value of 2.1 mg per dl. We have to calculate creatinine clearance for the patient. Creatinine is 2.1 mg per dl. Her body weight is 80. Age is also 80. How much will be the value? Can anyone calculate and tell me the creatinine clearance value? Is anyone working out? You want time?
Ma'am, is it 31?
No, it is. You are little nearer to that. You got 31 now.
31.7 ml per minute.
Okay. Is there anyone?
Ma'am, is it the creatinine level is 2.1?
Yes, creatinine level is 2.1 and body weight is 80 kg and she is 80 years old. 2.1 it is. She's a female patient. You have to multiply with 0.85 from the formula.
Okay, yes.
26.98, ma'am.
How much?
26.98.
Yes, good. 26.98 ml per minute. Yes, good. She got it correct like 30 and 31, but it should be multiplied with 0.85. Okay, you got the thing? Good. It is 26.9 ml per minute. Good. Okay. So second thing, here we have 53-year-old female patient creatinine is 2.6 mg per dl, whose body weight is about 60 kg. We are calculating creatinine clearance for this patient. Same with the formula, which is 140 minus age is 53. Okay, into 60. 60 is your weight, right? 72 into creatinine clearance, 2.6 for this patient. You will be giving it 23.7 ml per minute. Okay, is this guys okay? You got the point now? If you're clear with this is a step 1. So we have step 1, step 2, step 3 for the final renal dose adjustment of drugs. You will be now, you got how to calculate creatinine clearance. First step, you will be getting the creatinine value. That is your serum creatinine. Okay, from the problem. The other people in the session, you may be from first year, second year, third year, fourth year. So I need you guys to come with me. Okay, you guys will be having a basic. So I'll be telling you in brief this sum. The thing is, you will be calculating now the renal dose adjustment of drugs in your hospital. So first step is your calculating creatinine clearance. For that, you have to know what is the creatinine, which is this. What is the value of creatinine? It will be coming from your patient's case sheet. Okay, all the lab parameters in your ICU units will be having on booklet. In that, all the levels lab parameters will be given. That is creatinine 2.6 mg per dl, which is a 53 years old female patient. The weight is 60 kg. Okay, you will be calculating the creatinine clearance for this patient with your formula, which is 140 minus age, which is given, which is 53, into your body weight 60 kg by 72 into creatinine, which is 2.6. If male, you have to calculate it simply. If it is female, multiplied by 0.85, which is 23.7 ml per minute. Okay, all good now? Clear? This is your step 1. You got your creatinine clearance. Next, you have to know what are the guidelines. Okay, what is the guidelines you have to prepare, and you have to adjust by seeing your guidelines, how you will be doing it. Okay, so this is your second equation for calculating things, that is the glomerular filtration rate. First one, you will be calculating your creatinine clearance using your serum creatinine, age, and body weight. Okay, that is the first one is your Cockcroft equation. Second one is your Schwartz equation. This is quite tough, which that one will be first easier. Okay, so here EGFR is equal to K, that is a constant, which is the constant values I have given, into your height in centimeter by creatinine mg per dl. If the patient doesn't have any age, mostly the patient will be having weight and age in the patient. If the patient is being overloaded, you have to check again once again. Even if the patient is not having any weight, then you will be going with this formula. Okay, that is EGFR is equal to K into height in centimeter by creatinine mg per kg. That is K is equal to 0.33 in preterm infants, in full-term infants, and adolescent females and adolescent males. Okay. So this here goes our sum. We have 32 weeks preterm baby with a body weight of 1.1 kg and height 15.8 centimeter with your creatinine. So you're going to calculate it. So how you will be calculating it? K into height in centimeter by creatinine. You got 2.48 ml per minute. So can we have a resolving solution? Can I give you another one example for this to calculate? Your question will be, your question will be 13 years female with a body weight 38 kg and height 142 centimeter, had creatinine 2.5 mg per dl. So calculate creatinine clearance for this patient. How much it is coming now? 13 years female with a body weight 38. Okay, I'll tell you 13 years female. Height is 142 centimeter. Creatinine is 2.5 mg per dl. So how you will calculate? Height is 142 centimeter and creatinine 2.4 mg per dl. How much will be your value using this formula?
$31.
is good. The other people's, are you guys are aware now how to calculate it? Dose adjustments is always very easy. You can just play with your drugs for calculating doses if you're very thorough with your formulas. Okay. Okay. So it's 32.54 ml per minute. 31 is also good. Okay. You just go with your constant values because here the constant will be quite different for female infantil. Yeah. So here it is 0.55 for the female, 1 to 13 years. You have to be aware. Just note down the formula. Okay. For Schwarz equation, which is for the preterm infants, you have to correlate that what is the age of the people there so that you can use this formula. According to the age, the constant factors values will be differing. Okay. Okay. So here is your guideline. So this is your second step. You have to know your guidelines for all the dosage calculation methods. Always go with your international references when you go and practically do the dose adjustment units. Okay, that is antibiotic stand for ICMR, and pediatric neonatal, pediat.net, IAP, BNF, and stand for infusion drugs, global RPH, drug interaction, that is drugs.com, Netscape, calculator, MD Calci app. So that is will be a tool. MD calculator app you can install in your mobile so that you can use it as a tool, which will be very easy for calculating this creatinine clearance for the long-term purpose. Okay, and drug interaction is very important in our clinical pharmacy practice. You can use drugs.com or Medscape or Micromedex, which is a very standard one. Okay. Infusion drugs. Infusion of drugs is very, very important as clinical pharmacists. Kindly go through global RPH and Micromedex on all the PDF pamphlets of drugs. How you have to know administration techniques of drugs. Okay. Like, for example, if some drugs have to be given in IV, some drugs the doctor will write, you have to give the drug in subcutaneous, and sometimes you have to write in IM, it should be given. Okay. All the different type of routes, you have to be very aware of that. Okay. So that is your Stanford guidelines, which is a very standard guidelines we'll be using for renal dose adjustment. Okay. Okay, here comes your Stanford guidelines. I have given some text so that you can interpret and do. Okay, so can I have a session now? Interactive things. Okay, if the most commonly used antibiotic is your meropenem. Meropenem, carbapenems are the first one, which is your meropenem. Next is your imipenem. You have calculated creatinine clearance now. The value is 26 ml per minute. Doctor is writing imipenem 26 ml per minute. Kindly give me the dose adjustment. Okay. So first one, you want the creatinine clearance as 26 ml per minute. Then how it should be given? You just go through your guidelines. 26 ml per minute means it comes under CRCL 15 to 29. So if the patient have general indications, the dosage is 500 mg IV Q12 hours. So 1 gram per day. Okay, if the patient has 26 ml per minute. Like this, you will be correlating with your guidelines and you will be adjusting your dosages. Is everyone aware now? Can we have some questions now with your guidelines for calculating the renal dose adjustments? Yes. Okay, so this is your Stanford guidelines. Okay. I got the power cut here. So you guys got the point now? Okay, so for if the patient has been given meropenem, you got 26 ml per minute in previous one. Now, mostly we will get it as like 36 ml per minute of meropenem. What will be the dose adjustment of meropenem if the patient has 36 ml per minute? This is your standard guidelines. You can have various guidelines from here as I refer. Okay, you can kindly note down the guidelines for antibiotics, infusion drugs, drug interactions, and calculators. So, how much will be a dose now? Do everyone got what I'm trying to tell now? Can you get how to interpret the drug dosages with your renal dose adjustments? Can anyone tell me? Or you wanna explain me again? I'm also
Yes,
okay with that.
the renal dose adjustment for a creatinine clearance of 36 would be 1 gram IV quarterly 12 hours.
1 gram IV?
Quarterly 12 hours.
Yes. Good. If the patient has meningitis, then
2 gram IV quarterly 12 hours.
yes. Very good. So everyone also got the point where it came from. I need 5 or 4 people to tell me. You can also download and have your Stanford guidelines with you as your reference guideline. For all the people who want to be a clinical pharmacist in future, it will be very helpful according to your antibiotics and dose adjustments. Okay, so everyone understood the concept, how we are being correlating with that. So if you are being given an antibiotic now, can you calculate the creatinine clearance and adjust with your guidelines? And you have to give me the accurate value of dose adjustments according to your patient conditions. Then, third step, you have to see all the critical parameters in your critical candidates. One is your urine output value, which is very, very important. If the patient is volume overloaded or if the patient is volume underloaded, and you have to see the other critical care lab parameters for the patient. Okay. Okay. So everyone got the point? How will be correlating with it? Is this okay? So what will be your formula for this one? Okay. You guys are okay now? Okay, so this will be all your simple formulas. So just give a glance. Creatinine, calculate the creatinine is very important. You have to pick your creatinine from your patient's case sheet. Okay, which will be less than 5 ml, 5 or 0.05. Okay, it will be a value of 5 always. Creatinine clearance. If the patient has hemodialysis, if the patient has the condition of dialysis or hemodialysis for 7 to 14 days, then your adjustments will differ according to your guidelines parameter. for hemodialysis, SLED, and CRRT. Okay, so this will be a common formula for Cochran quality equation. CRC LML per minute is equal to 140 minus age into years into body weight by 72 into your creatinine. Okay, so this method is used to estimate creatinine clearance from your serum concentration level. Okay, this method considers both the age and weight of the patient. It is a very commonly used method. So I need all the guys to take your formulas here. Okay, then you can go with your clinical interpretation of drug calculations. So this is how you will be interpreting with your clinical case discussion. You have to work out your formulas. Okay, and then you will be having the calculation methods according to male and female parameters. And then the second equation comes, which is according to your height. If the patient is having the overweight or if the patient is having enigmatic condition, then we will be going with your Schwartz equation. Okay, which is will be calculating your height. Okay. This is your standard guidelines, all per references. Okay, so can we have the quiz now? Any around 3 to 5 people? Can you just interpret with your guidelines and tell me how you will be calculating? For neonatal, it differs. Okay, you can go with your MedScap, Micromedics, or Global RPH for the pediatrics. They will be giving some specific parameters if it is pediatric calculation. Okay, so we have 3 quests at last. So that I need you guys to just tell me so how you will be interpreting it. Okay, so we'll have a gentamicin, as she said. Okay, if the patient has the condition of a CRRT and your culture test has shown gram-negative bacteria, okay, the patient is advised to go with your clinician said to go with your aminoglycoside. So that is will be gentamicin. So what will be your CRRT value of that particular patient? If the patient has the creatinine of less than 10 ml per minute, or the patient has the condition of CRRT, which is like 3 ml per minute, and the urine output is nil for the patient, what will be your dose of gentamicin? If the patient has gram-negative bacteria in your culture, urine culture or blood culture, what will be your value? Can anyone tell me? Can you interpret and tell me? Why 5 people have gone? If any doubt you have, you can approach me directly now. I'll just explain you some first. Because in this session, it's renal dose system is very important, for all your critical candidates. I just want you guys to be very thorough with your formula and interpretations. Do anyone? Okay. Can I have for 1 more minute also? Okay, so it is 1.5 to 2.5 mg per kg. Okay, IV for 24 to 14 hours. If the patient has CRRT, see, here they have given a CRRT condition. If the patient has the condition of intermittent hemodialysis, the patient is undergoing dialysis, then you will be having the IHT dose, which is your 2 mg per kg IV loading dose, and then will be your maintenance dose of 1.5 mg per kg. That is your post-HT dose. If the patient has gram-negative culture. If the patient has gram-positive, then you will be going to 1 mg per kg IV for CRRT, and for intermittent hemodialysis, you will be having 1 mg per kg IV for 48 to 72 hours in that gentamicin. Okay, you guys are clear now? Okay, good. So for imipenem, you will be having IHT of 250 to 500 mg IV Q12 hours. Okay. And for Isberg also, no change. It will be the same. So can we have one more question now? Okay, we'll deep dive into meropenem, osmalthor, everything. Okay, this is for peptides. Okay, I'll ask for meropenem. Okay, according to the Stanford Healthcare guidelines, the patient was diagnosed with sepsis. Injection meropenem was prescribed by an ID consultant, which is an infectious disease consultant. Clinical pharmacists call for opinion for renal dose adjustment, which is creatinine clearance of 32 ml per minute. What will be a dose? Can anyone answer me? We have 3 quiz at last now. This is your last 10 minutes. Why all the people are silent now? Is that tough? I can see Bolam Prince, Kavya, Rasi, Harshita, Jagan, Shakti, and much more people. Deepika, everyone. Oh, I'm so sorry. You have been chatted. Oh, very nice. Yes, yes. So what you guys want now? 1 gram every 12 hours. So it's 1 gram. My computer has been stuck. Oh my. Okay. So can you see what is the answer now? Okay, 1 gram every 12 hours. I'll just go through it now. Sorry, my mic was off. Can you see now? So here comes your pip test. 2.25 gram IV TDS diluted to us. Okay, is that okay now? Okay, now it is audible now. So this will be your pamphlet. Okay, you can go through the Stanford pamphlet and you can interpret and tell me. Okay, so here a baby with neonatal sepsis was prescribed injection meropenem, which is a creatinine clearance is about 33 ml per minute. Here comes your value will be injection meropenem 10 to 20 mg/kg per dose, Q12 hours, which is diluted 20 ml. Okay, and that's over 3 hours. Is that okay? You go ahead with this one. So piptas, your PDF will be this one, Stanford PDF. So can we have some questions with your Stanford PDF now? Yes, I can see the chats. Any more chats? Okay. Okay, so can everyone answer now? I'll just go through the PDF. Okay, if the patient has been given ertapenem, okay, mostly what our ID people will do is first they'll give meropenem, then we'll be shifting to ertapenem. If the patient has the creatinine value of 26 ml per minute, how much will be your ertapenem?
500 mg IV quarterly, 24 hours.
Yes, very good. If the patient seen undergoes CRRT, how much will be then?
1 gram IV.
Q 24 hours. Yes, very good. So you guys got the point now? You guys are clear how to calculate the renal dose and hepatic dose adjustments? So if the patient have been given fluconazole and the patient has the creatinine of 46 ml per minute, how much it will be? 46 ml per minute. The patient has severe candidiasis. The indication is very severe candidiasis. It is whether IV or PO. How much dose it will be given? Guys, got the point now? Okay. Okay, as same for neonatal, your baby goes with the neonatal sepsis and have been given the adjustment. Then you will be going with your injection meropenem 10 to 20 mg per kg dose. Cutralast, just diluted 20 ml NS or 3 half because neonatal babies have different dose adjustment than your adults. Okay. So everyone okay now? Is everyone got the point of renal and hepatic dose adjustments? Anyone have doubts? How we will be using the formulas in renal dose adjustments for all the values, Cockcraft, for all the patients, and for all the infants and everyone. So everyone got it clear now? So this will be your antibiotic dose guidelines. And these are the guidelines. And these are your sums, which is very easy, quite easy. Okay. Okay. Thank you guys for the session. Do anyone have doubts now? Do anyone have doubts? Okay.
Ma'am,
Good. Yes.
some students were requested to provide input on antimicrobial stewardship practice and feedback form.
Okay, sure. We can have a sessions on AMS modules. So we are gonna approach for AMS modules. Anyone interested for being the AMS modules? Here we have our team will discuss with you about the classes. It is about 10 sessions and we'll be having a 5-day classes. Okay. We will be dealing about the introduction to AMS, that is antimicrobial stewardship program in critical care or tertiary care hospital. Second one, second class, you'll be dealing with all your principles and guidelines of AMS, antimicrobial stewardship. And third one, you will be having all the clinical interpretations of or calculations of antimicrobial stewardship of antibiotics with your infectious disease program. And fourth one, you will be having your clinical case discussions. And fifth one, you will be having the overall clinical interpretation and calculation of AMS program. What are the applications of AMS program? So we will be having any interested students to join the sessions of our AMS module. How was the session today? So soon we'll be having the AMS modules also. Is everyone interested for doing AMS programs with us? Or anyone need drug calculation, dose calculation methods? Okay, so some have given a heart. So Munira has given a heart. Okay, it's very beautiful to see from here. I'm very happy to see that. And any other students? Actually, we also have given session like dosage calculation method. We got students like around 100, we have like 60 to 100 people with us on board on for like before month. It was a very wonderful experience for them and for also for us. So soon we will be also operating for batch 2. And now some people have been requested for AMOS modules. So anyone interested for that, please approach the team. Okay, so how was the session today? Anyone got doubts with the renal dose adjustments? Are you being clear with your renal and hepatic dose adjustments? Okay, good. No, ma'am. No, ma'am. All was clear with your renal dose adjustments. Okay, that is very good. Can anyone people summarize here? How was the session? The session was too good, ma'am. Okay, thank you so much. So if people are being interested for any modules of dosage calculations on AMS modules, okay. So for early bird registration, soon you can approach our team. Yes, okay. I got 2 or 3 people here. Sure, our team will share you the PDF with you. Yes, sure, sure. We will be sharing your PDF with you, the Stanford guidelines. Okay, in your groups, it will be shared by our RX doctors team. Okay, and then okay, 3 people got interested. Other than anyone got interested to be doing with your AMS modules. Okay, okay. Thank you guys for the session. It was a wonderful session. Sure, we will share you the PDF with you.
Thank you,
Some
ma'am.
of Yes, thank you. So some of our AC inhibitors will cause increase in creatinine. Okay. So, but not all the drugs require creatinine clearance for the dose adjustment because it is according to your clinical condition of the patient. If the patient has a very good creatinine or eGFR rate, if the patient has been given AC inhibitors on attestation, if it causes increase in creatinine, then it may require dose adjustment. But in general, only in specific conditions, people require dose adjustments. Okay? Because AC inhibitors is very common in prescribing to the patients, right? If all the AC inhibitors requires adjustment, then it should be taken into consideration. But most commonly, all the high-end antimicrobials, restricted antimicrobials, will require renal dose adjustment and hepatic adjustments in transplant patients. Okay, Jagan? Thank you so much, guys. Thank you.
Thank you very much, ma'am, for your insightful presentation on renal and hepatic dose adjustments. Your clear explanation have given us valuable knowledge to apply in clinical practice. We sincerely appreciate your time and expertise in today's session, ma'am. Thank you once again for joining with us in SYCCON S6 Day 17.